Well, exactly. And that's one of the things, again, that comes up in the depression story is the NIMH. If you had become depressed in, say, 1970, and you had gone to NIMH literature, you know what they would have told you, the NIMH literature? Whether you get treatment or you don't get treatment, you're going to get better, okay? And you have every reason to believe it will not turn chronic because it's only a small percentage of people who end up with chronic depression.
What was that percentage? Was it under 5%?
Well, no, it was about maybe 10% of people entering with a major, we're talking about hospitalized depression, okay? Even the epidemiological studies of people so depressed, they're ending up in the hospital. Even among that group, it's only, 10, maybe 15% ending up with some sort of chronic long-term course.
Wow. So, I mean, that's another piece of good news. I mean, it's a really powerful piece that I frequently forget to mention, and is to emphasize that you're going to get better as long as you don't choose the drug.
Well, it is a very optimistic thing that I think, and right now people are said, take the drug and you're probably going to become chronic anyway. But yeah, the natural history message is a very, very optimistic one. I'll give you, here's what the NIMH said in 1974 to depressed patients. This is from Dean Schuyler, head of the depression section at the NIMH. As he wrote, most depressive episodes will run their course and terminate with virtually complete recovery without specific intervention. That's quite optimistic. Here's another one from in 1969, an NIMH publication. Assurance can be given to a patient and to his family that subsequent episodes of illness after a first depression will not tend toward a more chronic course. So it's here's another one. Depression is, on the whole, one of the psychiatric conditions with the best prognosis for eventual recovery with or without treatment. Most depressions are self-limited. Wouldn't that be nice to hear today?
Yeah, well, it's going to be heavily suppressed by the drug companies, that's for sure.
Yeah,
they do not want that message out.
No, of course not.
So, I mean, the message that needs to be shared is the one that you've really compiled and put together and really reinforced, is that you just, I just got to avoid these medications. I mean, now you study this really carefully. I guess the fear is, as a physician, that are there any indications, is there any subset of patients, however remote or rare, that may benefit from these drugs? Do you think they're ever clinically indicated?
No, I do.
Okay. All right. Good. So let's tell us who those people are. Because let me give you an analogy. I for the most part, I believe almost all statins, the drug used to lower cholesterol, are absolutely dangerous and should be avoided by almost everyone. But there's a small subset of people, about 1 in 1,000, who have a genetic disease. It's called familial hypercholesterolemia, and their cholesterol is usually run about 350 or so, and they seem to benefit from it. But that's 99.5% of people not needing it. So who are the people that you, in your evaluation review, suggest benefit from these approaches?
Well, let's show who shows up in the short-term clinical trials. There is a subset that really does do better than placebo, okay? And that's those with severe depression. So they're on the Hamilton scale. They're at a number that puts them in, quote, the severe category. And over the 6 weeks, they do seem to have, an abatement of their symptoms that's clinically significant more than placebo. So, and this, again, is what the National Institute of Clinical Excellence in Britain concluded, is that shows there's some rationale for using it in using antidepressants in that subset of depressed patients, even sort of as a first-line therapy. And then I think once you see that rationale for use, I think you still want to look at the long-term outcomes, even in severe patients. And given that in the pre-antidepressant era, severe patients regularly did, get better and stay better. By the way, the NIMH looked at this in the late 1990s. What is the untreated course of major depression today? And they found that those old epidemiological studies that showed that 85% were well at the end of a year still held true. You want to remember that. So I think the rational use would be in this subset would be, okay, use it to help people get out of the severe symptoms on a short-term basis. And as that happens, help them encourage to make changes, whether it be diet, exercise, get into community groups, join clubs, whatever it might be, and then help them wean off. Try to help them wean off after 6 weeks, 8 weeks. So use them as a short-term crutch. I think that makes sense.
Yeah. So, and I like the term crutch because it really applies the image of an acute injury, like you're in an accident or you fall on the stairs and you are physically wearing a crutch, and allows your bone to heal. in that time frame, and after that time, you don't wear a crutch the rest of your life, or certainly for months, typically.
No, exactly. So I think if you had a paradigm of care that said, okay, let's throw away the crutch and get people back to a non-medicated life, that would be terrific. And then the drugs would have, I'm talking about the SSRIs, and you pay attention to all their side effects and the risk of mania, and then they'd have a sensible, thoughtful use in place.
I like your approach, and I appreciate all you've done for helping us understand this at a deeper level. Are there any other pearls or wisdom that you'd like to share from the information you've put together?
Well, no, I just think the bottom line is this, is that, and when we're talking about antidepressants, people need to broaden their horizon in terms of as they try individually whether or not to go this route. And they've got to broaden their horizon that includes long-term effects, risk of, mania, risk of cognitive decline, and incorporate that into their decision-making process. And I think if they did so and see this long-term chronicity, people would be making different decisions. And last thing is this. The one thing, it seems to me, of people I interviewed that got better, and that depression is gone, they talk about sort of the agency, sort of making changes in their life that gave them a sense of control over, a little bit of control, and I'm not saying, control over their well-being. And I think anything that encourages that sense of control, that you can do things to at least minimize the risk, is a very good thing.
Excellent. Well, people want to learn more about the specifics. I'm sure they can look at your book, and can you give us the name of that book again? And I'm sure it's on Amazon.
Yeah, it's called Anatomy of an Epidemic. And again, my name is Robert Whitaker, so you can order it there, or you can go to Barnes & Noble or Borders, and you should be able to find it there as well.
Excellent. Well, thanks for all the work you've done, not only for this book, but for the many years you've put in to help educate us about the truth, and that really is clear. And that's one of my passions too. I'm a medical journalist, even though my initial training is a physician, but I'm a medical journalist and trying to help people understand, because they're just our lives are busy. The economy kind of is tanked, and we've all got things to keep us occupied, and we just don't have the time, which is really the key limiting resource for most of us, to evaluate these things like we need to, and it takes a lot of time to do that. So I really appreciate all the time you invested in helping uncover this, because it's a big story and it needs to be shared. So thanks for all you did.
Well, thank you for having me. It's my pleasure being with you.